prostate cancer is actually a cancer which is very common in the male population after the age of 40s. And we are mentioning about this one, there is anatomically, prostate is usually below the bladder, and the size usually changes with age because of the growth signal is androgen. Then this is how the anatomy of prostate gland look like. When there is a cancer, it can actually compress the urethra and affect the urinary outflow. Then we have mentioned it is very common, mostly above 40 years of age, is one of the most common type of malignancy in the main population. Then we have mentioned about different risk factor, but age is actually the greatest predictor, which is very common, and above the age of 40s, and we mentioned this one as well. So why it is very common in the older population is actually because of a greater lifetime exposure to the hormone. So the hormone testosterone is actually a known growth signal for the prostate. So we have also mentioned about the family history aspect is also very important, occupational exposure as well as diet. So high meat diet, there is a strong correlation between high meat diet. I think the chance increases like 2 times and above when someone is eating regularly with red meat. Okay, then we have mentioned also about 80% of the prostate cancer is hormone dependent. So the problem is mostly due to the androgen. Then we have also mentioned about in castrated men and even in cirrhotic patients, the incidence is actually very low because they do have almost low or no testosterone or androgen in the body system. That is why this population is actually not affected by prostate cancer. Then we have mentioned also about the pathophysiology of prostate cancer. Adenocarcinoma is the most common histological type of prostate cancer. Then we have also mentioned about how does this occur. It is mainly because of the active form of prostate, which is known as dihydrotestosterone. So remember, androgen can be synthesized even from the renal gland, as you all, for both male and female, but the percentage is actually very minimal. So most of the predominant type of androgen is usually what? It is a testosterone, which is mainly synthesized from the testes. So that one will serve as a growth signal, then which is responsible for the prostate cancer. Then I also mentioned about in the early case of the disease is mainly due to testosterone or dihydrotestosterone, but in advanced stages, the cancer actually can survive without getting signal from the circulating androgen. So in that case, we call it like androgen resistant or hormone refractory or androgen independent type of prostate cancer, which is very common in advanced stage of the population. So we have also mentioned about how hormonal regulation in the prostate gland carried out in the body system. Then, if you remember, we have seen some information about the clinical presentation of prostate cancer. When a patient is actually having localized disease, most of the time, the patients are asymptomatic. Yes. Then, in locally invasive disease, we are going to see urethral dysfunction. There is a problem in the frequency of the urine. But in advanced stage, as a result of involvement of distant organ, we are going to expect those problems. Okay, then when you look at the diagnostic modalities, digital rectal examination is part of the diagnosis modalities. You can also prostate-specific antigen, but usually this one is not really very specific for diagnosis because the level can also be elevated in benign prostate hyperplasia. So the confirmatory test will be biopsy from the site of the lesion. Then I have also mentioned about the staging of prostate cancer. So stage one is usually is located in the prostate. Stage 2 is large enough, but it actually involves both of the prostate, but still is confined with the prostate. But in case of stage 4, 3, the cancer normally spread beyond the prostate and involves the lymph glands or seminal vesicle. So stage 4 is when there's involvement of regional lymph nodes, we call it stage 4A. And when there is metastasis to distant organ, that is when we are going to say the patient was having metastatic stage of cancer. So I think the other information to note about prostate cancer is you have to know about the Gleason score. So remember, Gleason score is actually will tell you how is the similarity between the tumor cell from the normal cell. So sometimes, remember it is the pathologist, normally they take the sample from the biopsy and they conduct the score of the disease. So this one is actually very common even in our setting. So they measure the score. Then sometimes the Gleason score cannot be determined using the imaging techniques, but mostly if the score is actually below 6 or less, the tumor tissue is usually well differentiated and less aggressive and likely to grow more slowly. So that is why this one score will tell you the prognosis of the disease. So if there is 7, that means there is a moderately differentiated tumor, then but still might not spread quickly, but is moderately aggressive. But if the score is actually between 8 to 9, the tumor is fully differentiated or undifferentiated or highly aggressive, so it is likely to grow faster than and spread to distant organ. So that is why even treatment modalities nowadays is actually is they also consider the level of Gleason score. Okay, so this is something you are supposed to note in detail. Then the aim of today's session is to take you through in detail about how do we manage prostate cancer. So what are the treatment modalities available in our setting and what are actually the recommendation from different guidelines. So the goal of therapy, by the way, in the early stage of the disease, maybe we can say stage 1, stage 2 disease, the goal is normally curative intent. However, in case if the patient is actually very older population, maybe our goal is to minimize morbidity, mortality due to prostate cancer. We call it even watchful waiting. So this one is like we consider if the patient is very old and asymptomatic, there is no need to do surgery and there is no need to radiation therapy, specifically if the life expectancy is actually very short, considering the age of the patient. So, but in the early stage, maybe in the younger population, the goal of treatment is curative, and there is a role of surgery and radiation therapy is usually very prominent. Then, in advanced stage, the most common goal is usually symptomatic relief and maintain quality of life of the patient. So, what is the general approaches of the treatment? By the way, the initial treatment of prostate cancer will depend on what is the stage of the disease, the presence of the symptom, and the life expectancy of the patient. So those are very key. What kind of treatment modalities we are going to use for that patient? Okay, fine. So generally, what are the treatment modalities we are having currently? We do have both non-pharmacological as well as pharmacological treatment modalities in managing prostate cancer. So the first one is expectant management. So this one is just monitoring of the patient using the PSA, and digital rectal examination. Then the other thing you are going to note is occectomy. Occectomy is surgical removal of the testis, which is also very common, which is also very common part of pharmacological management. There is also radiation therapy, and there is also radical prostatectomy. Yeah? So this one is just surgical resection of the prostate gland itself. So, like, remember, we do have both non-pharmacological and pharmacological treatment modalities. So, from the pharmacological modalities, we do have luteinizing hormone-releasing agonists. By the way, the moment you give luteinizing hormone agonists, maybe in subcutaneous route of administration, is equivalent to doing oectomy. Both of them, they can actually achieve castration level. So they are known as androgen ablation therapy. So that means what kind of treatment you are going to pick is depending on the patient preference. If the patient is not willing to do oectomy, you can actually consider the other pharmacological treatment modalities that can cause equivalent androgen ablation like that of oectomy, mostly luteinizing hormone releasing hormone agonists, anti-androgen, combined hormonal blockage, estrogen, and chemotherapy. So chemotherapy is actually the last resort and mostly used in the hormone refractory uh, type of prostate cancer. Sometimes you have given agonists of luteinizing hormone, releasing hormone, then you give them anti-androgen, you combine both of them, but if you don't receive response, that is known as hormone refractory or androgen dependent type of prostate cancer. So in that condition, that is where you are going to consider chemotherapy. So by the way, if you see chemotherapy treatment protocol for prostate cancer patients, you expect that one is most likely hormone refractory condition. So maybe when you go to the Kenyatta University Hospital, you just find out what treatment modality the patient is on in case if you get prostate cancer patients. So in general, the hormonal manipulation treatment approaches for prostate cancers are divided into androgen ablation therapy and anti-androgen. So androgen ablation therapies are the surgical component, removal of the testes, the renal gland, even the pituitary gland. But the most common one is oectomy, which is the main source of androgen in the prostate. Then there is also luteinizing hormone releasing hormone agonists. We do have estrogen, luteinizing hormone agonists, progesterone, and cyproterone acetate are available. Then we do have also gonadotropin receptor antagonists so that they reduce the testosterone level by inhibiting gonadotropin receptor. We also have androgen synthesis inhibitor. Mostly, abiraterone is actually the most commonly used drug, even locally, from androgen synthesis inhibitor, because they are inhibiting the synthesis of androgen, but mostly they are considered in hormone refractory type of prostate cancer. And apart from that, we do have anti-androgen. By they, especially the flutamide, biflutamide, and nilutamide, those are the first generation anti-androgen, and also we do have the second generation anti-androgen in the lutamide. So especially anti-androgens are widely available in our setting. Then there's also a component of 5-alpha reductase inhibitor, finasteride, can also be considered in the early management of prostate cancer because they inhibit the conversion of testosterone to the dihydrotestosterone. Remember, dihydrotestosterone is the one which is the most common growth signal for the prostate gland and causes even malignant transformation. So if you give them this one, but most of the time by the 5-alpha reductase enzyme inhibitors are mostly used in the prevention, chemo prevention of prostate cancer when someone is having benign prostate hyperplasia or high PSA level. So those are the treatment options we are having currently in the market. Then we shall discuss in detail. The first one is expectant management. So when you say expectant management, it is just like observe the patient who is monitoring. So this one is usually considered when a patient is actually asymptomatic and very old population. Because the goal for older population is just palliative, so the possibility of cure might not be our primary goal because they are terminal age population. Then, like, what are you going to do here? You monitor the PSA level, and you do digital rectal examination every 6 months. Then sometimes even repeat biopsy in case of any disease progression. So those are the expectant management. So this one is just you monitor. So what is the advantage of expectant management? You avoid adverse effect associated with the definitive therapies. If you do radiation therapies, if you do radical prostatectomy, there are some adverse effects. So this one minimizes the risk of unnecessary therapy. So this is the advantages of expectant management. However, the disadvantage is there is a possibility of progression of the cancer and require more intensive treatment. So this is the major limitation in ways and usually considered in older population. Then the other part of the treatment is we call it androgen ablation therapy is oectomy. Surgically remove the testes, then you reduce the circulating level of androgen, then you achieve castration. By the way, we say castration is achieved when the level of testosterone is below 20 nanogram. If it is below, the probability of the circulating androgen to promote the growth of prostate is usually very unlikely. However, the major issue with oectomy, many patients are not surgical candidates, maybe due to their advanced age or due to the procedure is psychologically unacceptable. So because of that, this one is usually considered depending on the preference of the patient. Okay, so this one is just one treatment modality. The other treatment modality that can be considered in the early stage is radiotherapy. So remember, we do have external beam radiotherapy and we do have brachytherapy. If you remember what we have discussed in cervical cancer, brachytherapy is still actually one of the like site-specific type of radiation therapy available nowadays. So this one is usually reserved for low risk cancer patients is the oectomy, then the radiation therapy is usually considered in the early stage of the disease. Then the other thing is we do have also luteinizing hormone, releasing hormone agonists. So this one is just reversible method of androgen ablation, unlike oectomy. However, they are as effective as oectomy in treating prostate cancer. But the problem is the moment you discontinue, then there is a possibility like the androgen production can be enhanced. So currently we do have different treatment modalities, leuprolide, we do have depot, we do have implant of leuprolide, and we do have even goserelin acetate. So those are the available agents. Then leuprolide acetate can be administered once daily, but the depot can be either once monthly, once every 3 months, or once even every like 4 months, depending on the formulation. So we do have an implant or a depot that can be given every month, every 4 years, every 3 months, and every 4 months. So this one is usually very effective agent even in advanced stage of the cancer, and the response rate is usually 80%. By the way, the whole idea of giving luteinizing hormone releasing agonists are usually the moment you give them, initially they are promoting the production of androgen, but later on there is actually down regulation in the production of desensitization. So in such a way, initially they promote the release, but later on they inhibit the production by inhibiting normally the luteinizing releasing hormone from the hypothalamus. Okay, then in terms of even ADR, low incidence of cardiovascular adverse effect as compared to the estrogen component. So one typical example for GnRH agonists is goserelin that can be given subcutaneously. Then it is usually given every every 3 months. So you normally continuously give until disease progression or unacceptable toxicity is usually achieved. However, the issue with luteinizing this class of drugs are they are usually contraindicated as a single agent when a patient is having impending spinal cord compression or urinary obstruction due to the potential exacerbation of the symptom. We call it like tumor flare-up. Remember here, they normally promote the initial release of the hormone or initial production of the androgen. So if you don't actually, if you give them immunotherapy, it can worsen. So because of that, Usually, for advanced stage of the disease, this class of drugs are not usually given as a monotherapy. So it has to be combined with anti-androgen to prevent the tumor flare-up in the early course of the treatment. Then, was there any difference among the luteinizing hormone releasing agonists? According to a meta-analysis reported, there is no difference in efficacy or toxicity between this class of drugs. So therefore, the the treatment or picking or selection of the drug will be depending on cost, patient preference, and dosing schedule. You know, sometimes if they need every 3 months, some they take they prefer every 4 months. So it's just up to the patient to decide. Then very important information to note with when you give them goserelin or leuprolide, there is a disease flare up during the first week of therapy. So this one is due to initial induction of luteinizing hormone and follicle stimulating hormone by this class of drugs. So this one is very important. So it is usually manifested by bone pain and increased urinary septum, but mostly it usually resolves after 2 weeks of treatment. So that is why in advanced stages, by the way, or to prevent the tumor flare up in the first 2 weeks or on the first week of treatment, usually is usually combined with anti-androgen. So generally, that is one thing you have supposed to note. Then don't forget about the possibility of erectile dysfunction, injection site reaction, and decreased sexual desire, and including impotence can happen with this medication. Okay, then the other class of drugs we're having in managing prostate cancer is anti-androgen. So from this one, I've already mentioned about this class of anti-androgens are widely available. They are actually less effective as a monotherapy as compared to luteinizing hormone agonists. Yes. However, between themselves, there is a similar efficacy. So whether you pick flutamide or bicalutamide, there is no difference in terms of outcome. Yeah, that is why if you don't see any efficacy with flutamide, you're not supposed to use even with bicalutamide. Yeah. Yes. Okay, so this is another information to note. Then these objective response are usually manifested as when you give them anti-androgen, there is reduced inborn pain. You'll see even a reduction in the prostate size and decrease in the PSA level and improve in performance status. So those are the objective responses. By the way, if someone is really interested even to assess treatment outcome in prostate cancer patients, they can actually even look at it like those objective responses are the measure. So, like if a patient is on anti-androgen, how is the response of the medication? So, if the PSA level is significantly reduced after the treatment, no change, how is the performance status of the patient? So, those are some of the parameters that can be considered as one study areas, maybe if you are interested in the future. Okay, then usually indicated in combination with androgen ablation therapy for advanced prostate cancer. Remember, in advanced prostate cancer, there is a possibility of irreversible blockage or irreversible dysfunction as a result of the tumor flare-up. So we don't give anti-androgen, we don't give, sorry, luteinizing hormone, releasing hormone agonists as the monotherapy in advanced stage of the disease. So it has to be combined. So most of the time we call them even combined hormonal blockage. Okay, so this is the dosing schedule. By the way, all anti-androgens, what we are having currently in the market, are usually given with oral route of administration. So like flutamide, the common strength we do have is 250 milligrams. So it is usually given 3 times per day, yes, continuously until toxicity is normally achieved. Then bicalutamide, the most common strength we do have is 50 milligrams, then we normally give every day. Nilutamide, we do have 300 milligram strength for the first 1 month. We give them 300 milligrams, then After that, we reduce the dose. So it is just like giving loading dose. So those are some of the dosing strategies. So remember, when you give anti-androgen, there is a possibility of gynecomastia can happen. I think this one is almost common for all, and you have to also look at the liver function test is actually very important because they can cause derangement of the liver enzymes. So those are some of the adverse effects you expect when you give anti-androgen. Then the other treatment options we're having is combined hormonal blockage. Remember, combined hormonal blockage is actually is also known as maximal androgen deprivation therapy or total androgen blockage. You can reduce synthesis or you actually block the receptor, the binding of androgen to its receptor. So the whole idea is the rationale to give combined hormonal blockage is to interfere multiple hormonal pathways to completely eliminate androgen action. So by the way, the most extensively studied combination therapy is either this one, utilizing hormone releasing hormone agonist, or orchectomy along with anti-androgen. So this one is the most extensively studied combined androgen deprivation therapy. So you can imagine this one reduces the production of testosterone and orchectomy prevents the production of testosterone, but this one anti-androgen blocks the action from the binding of androgen to androgen receptor. So this one is usually considered when a patient is having locally advanced and advanced stage of the disease. By the way, most of the time, even in advanced stages, they usually start with this one. Then if they don't see any response or castration level is not achieved, that is when they are going to consider chemotherapy. So this one is also very important even in preventing tumor flare, particularly with those advanced metastatic stage of the disease. So even according to studies, is most beneficial for improving survival in patients with minimal disease. So they're actually the most commonly used treatment modalities nowadays. Then the other one, which is not commonly used, is diethylstilbestrol, which is a type of synthetic estrogen. It can be used as the mainstay of prostate cancer, but it is carcinogenic as well as teratogenic. So because of that, it has a lot of even cardiovascular mortality and risk. So because of that, nowadays, this one is really a preferred management if you want to really reduce or causes androgen ablation. So this one is not commonly used nowadays, so we don't really discuss for a long time. Then after that, those are the primary treatment modalities. So remember, in the early stage, either you do surgery or radiotherapy. Those are the recommendation most of the time. But if the patients are not comfortable, that is when you are going to initiate the anti-androgen or luteinizing hormone releasing agonists. But mostly in advanced stage, you combine the two. That is the general recommendation. However, if the patient is not responding to the primary treatment, that is when we are going to consider second line therapies. So the second line therapies, remember, all the drugs, what all the treatment options, what I have said is actually the same. So what are the second line treatment modalities we are going to use? For a patient who progress after their initial therapy, depending on what was used for initial management. So for second line therapies, you look at what management the patient was initially taken. Then after that, you decide which treatment option as second line to be considered. By the patient was on radiotherapy, then in case if radiotherapy is failed, you can consider radical prostatectomy. Yeah, that is an option. Or alternatively, androgen ablation can be used in a patient who progresses after either radiation therapy or radical prostatectomy. If a patient has failed, maybe you can consider androgen ablation therapy or cectomy or the pharmacological treatment modalities. Then please listen carefully as well. There are also secondary hormonal manipulation that can be considered as a second-line agent. So in case if the testosterone production is not suppressed with this agonist alone, maybe you add anti-androgen. So that one can achieve complete suppression, that is complete blockage. That could be an option. You have given initially with gostrolin, but if you don't see maximum response, you combine to anti-androgen. Then other thing is withdrawing anti-androgen in the patient receiving combination therapy. By the way, there is a scenario whereby you give them combination therapy. That means LHRH agonists plus anti-androgen. So how does this manipulation will relieve symptomatic improvement? Remember, when you withdraw anti-androgen from the combination therapy, it can actually even causes some additional symptomatic relief. The reason is why when you give them anti-androgen for longer period of time, there is a possibility of mutation of anti-androgen or androgen receptor. So this one, when it undergo mutation with continuous blockage, what will happen? It can cause anti-androgen compounds to act as like an agonist. So the patient is actually, you give them, but because of that mutation, now what will happen? This one will serve as an agonist and it can actually worsen the condition. So that is one strategies we are going to consider at the form of hormonal manipulation. You give them combination therapy, but the condition is really worsening. Then there is a possibility where androgen can actually undergo mutation. Then when you withdraw anti-androgen, there is a possibility of some relief. Then the other option is use inhibitors of androgen synthesis, aminoglutamide. I don't know about the availability of this medication in ways, but those are the strategies we can consider as second-line treatment modalities. Okay, now in case if a patient is actually having inadequate testosterone suppression, like if the testosterone level after treatment is about 20 nanogram per deciliter, it can be treated by adding anti-androgen or performing an oectomy. So like you have given the treatment, but still you are not able to achieve, so you can combine anti-androgen or you do what? Oectomy can be considered. Then in case if castration is not achieved, despite you give them, this is where we call them androgen independent disease. So which is very common, specifically in advanced stage of the disease. So like the prostate cancer can survive without even getting the androgen, circulating androgen. So because of that, here most of the time the treatment is actually palliative with chemotherapy or maybe analgesic for the pain, corticosteroids as well as biphosphonate if there is a bone involvement and local radiation therapy. But the goal here is only for palliative treatment. So this is an option, by the way. So the most common treatment modalities we're having currently in the market, when a patient is having hormone refractory prostate cancer, you have given all hormonal therapies, but you don't see an improvement in the PSA level, in the performance status, in the tumor size. That is when you are going to say hormone refractory prostate cancer. So chemotherapy with docetaxel, prednisolones can improve survival in this patient population. By the way, the rationale to use prednisolone, do you know steroids normally inhibits production of, they actually inhibits androgen production from adrenal gland. Yeah, that is why steroids are used in management of prostate cancer because they inhibit the production of androgen from the adrenal gland. In such a way, they can be used in the hormone refractory prostate cancer. So docetaxel 75 milligram, prednisolone 10 milligram once per day. Then this one will continue for 21 days. Then you repeat. You repeat every 21 days. So in a sense, prednisolone will be continuously given with 10 milligram or divided dose, but docetaxel will be given every 21 days. So a recommendation is up to 10 cycles, but it can be continuously given until disease progression. Yes. So this is the most common treatment modalities in the hormone refractory treatment. The other one is the second generation anti-androgens are nowadays, I think enzalutamide is the only second generation anti-androgen that is very effective in management of castrate resistant prostate cancer. Yes. Sometimes even the first generation failed, you can actually even use yeah, this one. So it normally improves overall survival, yes, in those patient population. So these are the doses, 160 milligram PO once daily. So those are the second line strategies that can be considered in case if the patient cannot tolerate chemotherapy. Then please also listen carefully. There is also another second line therapy that can be used in advanced stage of the disease is abiraterone. By the way, abiraterone is currently available locally, which is considered in the hormone refractory type of prostate cancer. Remember, despite you give them androgen deprivation therapy, androgen synthesis can continue to occur in the periphery, mainly in the adrenal gland or within the tumor itself. So we have already given androgen deprivation therapy so that androgen will not be sensitized in the testes. However, there is a possibility that can actually continue to produce in the adrenal gland. So the family of cytochrome 450 enzymes are usually apply in synthesis of androgen from the renal gland. So what does this abiraterone do? It normally inhibits this enzyme. So remember CP17A1 inhibits the conversion of pregnenolone to this type of androgen precursor. So which is a prerequisite or a prerequisite precursor for the production of testosterone. By the way, almost all steroids are derived from cholesterol, then it should undergo a little metabolic pathway to produce. So for testosterone production, the conversion from this one to this one is mandatory based on this enzyme. So abiraterone normally inhibits this enzyme and reduces the androgen-induced production from the renal gland. That is why it can be considered. So abiraterone can actually reduce testosterone production when it is combined with continued androgen deprivation therapy. So you have given androgen deprivation therapy, but when you combine it, you actually completely suppress testosterone production. Then the major problem with abiraterone is because of inhibiting this enzyme, you know, in the adrenal gland, I will show you the figure later. By inhibiting this enzyme, this one is actually the synthesis of steroid from adrenal cortex. So remember, cholesterol is the precursor. So cholesterol can produce aldosterone, cholesterol can produce cortisol, cholesterol can actually produce androgen, and androgen can undergo aromatization to produce estradiol. So you can actually even imagine there are different enzymes that are involved in the biosynthesis of the steroid hormone from adrenal cortex. So look at this enzyme, 17 alpha hydroxylase enzyme. So 17 alpha hydroxylase enzyme normally inhibits the conversion. It normally inhibits the conversion of progesterone to 17 alpha hydroxylase enzyme. Then remember, if this enzyme is actually inhibited, now there is a reduction in the synthesis of androgen. However, if abiraterone, by the time abiraterone is inhibiting this enzyme, now there is a lot of pregnenolone, progesterone is available, so this one will produce more of mineralocorticosteroid, which is known as aldosterone. So the problem is the moment you inhibit this enzyme, there is a lot of buildup of progesterone that can produce mineralocorticoid aldosterone. So because of that reason, when abiraterone can increase mineralocorticoid excess, this one will contribute primarily adverse effect of abiraterone. Okay, so because of that reason, it can cause fluid retention, it can cause hypokalemia, can cause hypertension. So do you know why it causes fluid retention, hypokalemia, and hypertension? Is there anyone who is willing to try?
Can I try?
Yes, please, Anit.
We know that aldosterone is a water hormone, so it helps in excess water removal. So when it's not there, then there's going to be a lot of fluid retention. And also because when water is being removed, also excess sodium is being removed. So if excess sodium is not being removed, and it also means potassium is not being removed. So it will also cause hypokalemia.
So what is the primary action of aldosterone, Annette? So we have said abiraterone promotes excessive production of mineralocorticoids. So what is the primary action of aldosterone? It causes what?
I think it removes excess water excretion.
So is there anyone who can support her? What is the primary action of aldosterone? Huh?
It retains water and salt.
Yes, the primary action of aldosterone is actually sodium and water retention. That is why we are going to see edemas in liver patients. Huh? As a result of what? Central hypovolemia, the renin, angiotensin, aldosterone system will be activated. So you'll see an edema in the peritoneal cavities as a result of like reduced oncotic pressure due to reduction in albumin level. So if you see excess sodium and excess aldosterone means there is sodium and water retention. However, it actually promotes elimination of hydrogen ion and potassium. That is why there is fluid retention. As a result of retention, there is hypertension can be developed. Then, as a result of elimination of potassium, there is a possibility of hypokalemia. So, as a home take message, when you give them, when a patient is actually taking abiraterone, you are supposed to monitor the potassium level and even look at it, the possibility of fluid retention and hypertension, because it promotes the production of what? Mineralocorticoid excess. Then apart from that, remember abiraterone normally abiraterone absorption will be enhanced with food. So because of that, 1 hour before meal or 2 hours after meal is usually recommended to reduce those adverse effects. If you give them along with food, it actually promotes absorption, so you'll see significant adverse effects. So those are actually the rate limiting toxicities of abiraterone. Yes, so this is the reason I've already mentioned about this. So by the moment you inhibit this enzyme, there is a buildup, so it produces more of aldosterone, ultimately causes fluid retention. So you can actually even see is most commonly given like in case if the patient is not responding docetaxel plus prednisolone, maybe you can consider even abiraterone plus prednisolone. So abiraterone, by the way, we do have a strength of 250 milligram and also 500 milligram. So the total daily dose and the chemo and the management of advanced stage of prostate cancer is usually 1,000 milligram once per day. Then we still normally give prednisolone. Remember, you know those things they do have like what kind of effect? They do have synergistic effect. Abiraterone inhibits synthesis by and also prednisolone normally also inhibits synthesis of adrenal androgen. So they do have synergistic effect. So this one is usually given in metastatic type of prostate cancer patients. So you have to note that one as well. Okay, so this is all about. So I think as a summary, for advanced stages of the disease, mostly abiraterone, prednisolone, docetaxel plus prednisolones are usually commonly given in our setting. So when you go to the hospital, in case if you get your counter check, what treatment option the patient is actually on. Then as a summary, how do we manage prostate cancer in low risk and intermediate risk patients? By the way, in low risk means like they do have low glycemic score, and even the PSA level is actually very low, less than 10, and the tumor grade is actually very low. So in that condition, if the expected survival life expectancy of the patient is less than 10 years, you normally give either expectant management or radiation therapy, because based on the clinical parameter of the patient, the tumor grade is actually very low. You can consider radiation therapy, or you can actually even consider radical prostatectomy in case if the survival life expectancy is above 10 years. Then intermediate risk is when the glycemic score is 7 or PSA is between 10 to 20 nanogram per ml, but the expected survival time is less than 10 years. Now you can consider expectant management or radical prostatectomy with or without lymph node dissection or radiation therapy, or without for, like it is normally depending on like the oncologist, what treatment modalities they are going to actually prefer. So you can, those are the option in intermediate grade. So there is a possibility of radical prostatectomy, that is the surgical component. Even there is a possibility of androgen deprivation therapy with the oectomy or even other luteinizing hormone releasing agonists. Then in high risk, by the way, in high risk, like the glycemic score is high, PSA level is very high, mostly androgen ablation therapy is usually recommended along with radiation therapy. So this is the general recommendation. So in locally advanced stages or very high, like advanced stages of disease, mostly androgen ablation therapy, either monotherapy or in combinations are usually recommended. So what are the androgen ablation therapies? It is a surgical component like oectomy. There's also a pharmacological component like the luteinizing hormone, releasing hormone agonists. So those are the consideration we are going to give. But in case if the patient is hormone refractory, that is when we are going to consider chemotherapy or abiraterone along with prednisolone. Okay, then that is all about prostate cancer management. Then finally, how do we monitor? Mostly the PSA level is very important, but of course we can actually even see the size of the tumor, and even resolution of the symptoms is usually the most important monitoring parameter. So by the following definitive therapy, the PSA level should be checked every 6 months for the first 5 years, then annually for after 5 years, because the recurrence rate is usually very high in the span of like in the first 5 years of definitive treatment. So this is all. Then apart from that, what are the parameters that can determine the prognosis of prostate cancer? Histologic grade is very important. The tumor size and the local extent of the primary tumor. Specifically, the Gleason score is actually the most common histological grade that can determine the prognosis. So if the score is actually between 9 and 10, this is actually very aggressive, fast growing. Prognosis will be very, very poor. So this is all what I have about prostate cancer. Now it is time to hear a few questions from you before we conclude the session of prostate cancer. Any question? Any questions so far? Between lung cancer and smoking, specifically with long-term smoking, like 10 years and above. Some literature says 15 years and above, and etc. Yes, but smoking is not the only factor that can actually increase the risk of lung cancer. So this is how lung cancer look like. This is actually the tumor. By the way, when they do have a tumor, they usually cough, sometimes even blood in the sputum. Then you will see even pleural effusion, then shortness of breath. Because of the effusion, it can impair gas exchange. So those are very common complaints with lung cancer. Then what is the expectation at the end of the session? At the end of the session, you are supposed to identify the major risk factor for development of lung cancer, identify the staging of lung cancer, then finally you have to outline the treatment modalities for small cell and non-small cell lung cancer. So what is lung cancer? Yes, Tiffany.
So I have a question.
Yes, please.
When we know that the lung is one of the places that most cancers metastasize to, so is that still lung cancer, or it's just a very advanced form of the primary cancer?
No, when you say cancer, naming of cancer should be from the primary origin. But then when the pathologists do cytological analysis, they can easily capture whether the primary origin is from the lung or from other cells. So if the lung is involved as a result of cancer from other sites, so it is not a lung cancer, it is actually a cancer which is metastasized to the lung. For example, a patient can have colorectal cancer, but metastasized to the lung. Mostly by the lung involvement is actually the most commonly affected organ. Then because of the circulation. So then that is not a lung cancer, despite but it is a colorectal cancer involving or metastasized to the lung. So when you say about lung cancer, we are discussing the primary origin of the cancer is only in the lung. That is when we call it lung cancer. So I hope you get what I said, Tiffany. Yes.
Yes, sir, thank you.
Okay, good. So this is uncontrolled growth of malignant cells in one or both lungs, and even in the tracheobronchial tree, by the way, can involve one or both, and even the tracheobronchial trees. So originated from the bronchial epithelial cells. So this is how the lung cancer look like. Then epidemiologically, it is actually like is the second most common cancer case of cancer worldwide. According to the Global Report of 2020, lung cancer is actually the second most common cancer globally in both genders. Yes, the first one is breast cancer. So incidence and mortality is slightly higher in male. I think males are more of a smoker. Yeah, I think that is why when they do epidemiological studies, that is why most of the incidents are actually very higher in males because they are involved in more smoking, drinking as compared to female. Then the incidence and mortality in black male is actually very high. So still the same justification they are saying. Black people are actually more involved in those kind of smoking activities as compared to the white male. I don't know whether this really a conclusive study. But anyways, according to the Global 2020, lung cancer accounts like 11.4% of the total cases in both gender of all age group. So the first one is breast cancer, lung cancer, then others will follow. Then smoking is actually the most important risk factor. But smoking normally has a chemical substance. But then do you know, like in cigarette, it is not only nicotine that actually that is only found in cigarette. There are many things which is found in which in nicotine that can actually increase risk of cancer. So far, there actually a strong correlation between smoking and lung cancer. Then it is mostly based on the pack year. So the higher the pack year, the higher the risk of developing lung cancer. But as I said, in contrast this one, there are many smokers that does not have any lung cancer. Okay, so there is a possibility of environmental factor. This is related to the passive smoking. So, some people, they normally, if you are living in a smoking zone, you are actually inhaling every time. Yes, sir. But anyway, the pack here is actually the most key determinant about the possibility of having lung cancer. There are also there are some carcinogenic chemical substances, maybe asbestos, arsenic, nickel, then chromomethyl ethers. They can actually predispose you to develop lung cancer, according to some epidemiological studies. Then there is also a component of genetics has some role. Yeah, if family history of lung cancer, there is high risk. Then the other thing, normally there is some genetic component like metabolic enzymes that process carcinogen predispose you to develop a lung cancer. Remember, the smoke chemicals are activated and deactivated by a certain phase 1 enzyme and phase 2 enzyme. Remember phase 1 enzymes are usually activating, but deactivation is more normally. Phase 2, when a drug molecule undergo or a chemical substance undergo phase 2 metabolism, they're actually in the process of elimination. So this is normally deactivation. So in case if a patient is actually having deficiency of phase 2 enzyme, there is a reduction in the clearance of carcinogen. So the patient will having high risk of lung cancer. Or if a patient is having or induced like those cytochrome 450 enzyme, remember the principal enzyme that is involved in phase 1 metabolism of drug is usually cytochrome 450 enzyme. So there is a greater risk because there is high rate of formation of active carcinogen. So elevation in phase 1 enzyme and deficiency of phase 2 enzyme predispose the patient to have lung cancer. Okay, then, as I said before, lung carcinoma. Makina?
So I have a question. What about COPD? Is it a risk factor for lung cancer?
Okay, this one, let me check. But smoking and lung cancer is highly correlated. But I am not very sure about whether COPD is a risk factor for lung cancer. Maybe let me do a quick check. Is COPD a risk factor for lung cancer? Okay, yes. So it says, according to my quick search, it is well known that COPD is a significant risk factor for lung cancer, and approximately 1% of COPD patients develop lung cancer every year, which might be associated with genetic susceptibility to cigarette smoke. So according to this study, there is a correlation between COPD and lung cancer. Yeah, good question, and thank you. I didn't even imagine in my mind. Yes. Okay, good. So even other study shows normally it is 1%. Yes, if the risk of having lung cancer ranges to 1%, if they do have COPD. Yeah, but the most common cause of COPD is actually smoking. I don't know whether it is just because of, but smoking is just one factor for COPD. But mostly in our cases, most of COPD patients are having chronic use of chronic smoking of cigarette for many years. Okay, good. Thank you. Then lung cancer arises from the normal bronchial epithelial cells after exposure to carcinogens. I hope by now you know what is carcinogen. Then this carcinogen can be acquired because of genetic lesion. So it could be because of activation of proto-oncogene. It could be because of inhibition of the tumor suppressor gene. It could be actually due to the production of autocrine growth factor that can promote proliferation in malignant transformation. So in such a way, when there is an exposure to carcinogen, because of this, now there is high risk of developing lung carcinoma. Then what will happen? Remember, as the tumor grows, now the cell may dislodge from the tumor bulk and enter the hematological or lymphatic circulation. So do you remember what we have mentioned at the beginning of the introductory session when we were discussing about mechanism of cancer spread? Yes, some causes locally spread, some normally join to the circulation, and some undergo lymphatic system involvement. So in such a way, there is metastasis to the bone, liver, and central nerve system. But then in most of the cases, the first site of metastasis is usually the lung. Yes, because of if they join to the circulation, even in other cancers, they usually involve first cancer, but it is not always true. Okay, now let me take you through about the histological classification of lung cancer. By there, lung cancer are broadly classified into two categories, non-small cell and small cell. By the way, why they say small cell, when they look at it, the cancer cell under microscopy, they're actually the size of oats. Yeah, because of that, that is why they are called small cell. But then the small cell is actually bigger. So this one is just normally a pathology report that will tell us whether it is a non-small cell or a small cell. So it's small and non-small is just based on the size under microscopic observation. So apart from that, the most common histology is 80% of all lung cancers are usually non-small cell. But most of the cases you will get when you go to, maybe in case you can also check when you go to Kenyatta University, yes, you can actually see most of them are non-small cell carcinoma of the lung. Then small cell accounts 20% of all lung cancer. So remember, the major issue with the small cell carcinoma is the early metastasis rate is very high. Even the doubling time is actually very short. So that is the unique features of small cell carcinoma. Despite this, they are very sensitive for chemotherapy and radiotherapy. Then apart from that, another information to note with lung cancer, by the lung cancer can actually causes SIADH, syndrome of inappropriate secretion of antidiuretic hormone. By the like there are some drugs like the Vinca class of alkaloids, they can actually cause SIADH. That means they promote the production of antidiuretic hormone and there is excessive water accumulation. So that excessive water accumulation can actually causes dilutional hyponatremia. So don't be surprised if you see low serum level when a patient is actually having lung cancer. It could be because of accumulation of antidiuretic hormone causes dilutional hyponatremia. Okay, then whereas the non-small cell carcinoma, like they are very common and the early metastasis is not very as such, they are actually very poor in terms of sensitivity for chemotherapy and radiotherapy. Yeah? So that is the main difference between the two. But non-small cell is very predominant. The non-small cell has also three categories: adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. But adenocarcinoma is the most abundant type of non-small cell carcinoma of the lung. So this diagram is to show you about the difference or the different characteristics of the non-small cell and small cell carcinoma. Small cell accounts the smallest percentage, but however, they're actually having shorter doubling time, and also they are highly sensitive for chemotherapy and radiotherapy, and relative risk of metastasis is usually very high. Contrastingly, non-small cell, they are actually predominant clinically. The doubling time is usually very long. They're actually low sensitivity for chemo and radiotherapy. They do have a medium to low risk of metastasis to other distant organs. So this is the difference in terms of the tumor characteristics between small cell and then small cell carcinoma of the lung. Then, according to WHO TNM classification, non-small cell carcinoma can be staged from stage 1 to stage 4. Stage 1 is usually confined to the lung tissues, but stage 2, there is the lung tissues and lymph node in the lung. The lung is involved and also lymph node of the lung is involved, but stage 3 is where the lung tissue and lymph nodes outside the lung is usually involved. Like the nearby lymph nodes are usually involved in stage 3. By the way, as I mentioned at the beginning, when we are discussing about the staging, don't worry about the staging, because that is not really the role of the pharmacist. But you have to know when you say stage 1, what does it mean? When you say stage 2, what does it mean? When you say stage 3, what does it mean? When you say stage 4, it is definitely the cancer undergo metastasis to distant organ. So liver, renal gland, bone, brain, or other sites. So this is how the staging of non-small cell carcinoma. Then this one, stage 1A to A, they are known as localized disease. Locally advanced is usually stage 2B, stage A, and stage B. Advanced stage is usually stage 4B and stage 3B and stage 4. This one is just metastasis to the distant organ. Okay, but stage 3B, despite it is advanced, there is no metastasis. But then remember M0 and M1. M0 means no metastasis. M1 means there is metastasis according to TNM staging. Okay, then now the small cell carcinoma of the lung, the staging is actually different. The staging for a small cell cancer is they put it either limited or extensive disease. So the limited one is usually the cancer is on one side of the chest or the tumor involves on only one lung. However, when you say extensive, there is a spread throughout the lung to the other lung. It could be involvement of the other lung or spread throughout the lung, or it could be actually even metastasis to the distant organ. Huh? So when there is a metastasis to the distant organ, that is, they call it extensive disease, but it is limited within the lung itself. That is where they are going to call it limited disease. But from small cell lung cancer, the extensive disease ones are actually the most common epidemiologically. So 60 to 70% of the cases are usually extensive disease. So you have to know this information too. Then, having said this preliminary information, now let me take you through about the clinical presentations of lung cancer. So what do we expect? There are pulmonary symptoms and extrapulmonary symptoms. So extrapulmonary symptoms usually happen when there is involvement in other tissues. Huh? Okay, so pulmonary symptoms are usually the most common, and usually they appear first, and they are actually the most common. So how do they present? Cough, shortness of breath, chest pain, shortness of breath, dysphagia, hemoptysis, and pleural effusion. But then if you see those symptoms, those can be even symptoms of heart failure. And even those can be symptoms of even pneumonia. So because of that, it is very hard to, to differentiate or to suspect lung CA based on the clinical presentation. However, they normally even see the tumor when they do a simple chest X-ray. Then extrapulmonary symptoms are when there is a tumor involves tissues outside the pleural cavity. So there is a possibility of bone pain if the bone is involved, adrenal insufficiency, confusion, personality change. This one is when there is involvement of the brain, and weight loss and seizure and enlarged lymph nodes can happen. So those are some of the clinical presentation. So how do we came up with the diagnosis of lung CA? Is usually history and physical examination, a very important imaging, CT scan and chest X-ray, then tumor sampling, either corneal biopsy and bronchoscopy. Can you see normally this procedure, bronchoscopy, yeah, is normally to see the airways and check for any abnormalities. As you can see, the patient is actually, so they put a guided wire and they look at it, how the airways look like. So this procedure is known as bronchoscopy. So those are some of the, but the most confirmatory diagnosis is usually the corneal biopsy is a confirmatory test for lung cancer. Then I don't know whether I want to, okay, I think we can stop here, then we continue the management when you come at 11. So maybe, do you have any questions so far? Any question? Then, very responsive to chemotherapy and radiation. Yeah, so chemotherapy with or without radiation therapy is usually the treatment of choice. But especially in extensive disease, usually chemotherapy, then after remission, that is when we are going to consider radiotherapy. I will come to that. Now, when there is a limited disease, that means the disease is actually confined with one lung. So etoposide and cisplatins are the regimen of choice. So they are actually effective, along with concurrent radiotherapy. Okay, then from this, but in case if the patient is not actually having some toxicity issues with cisplatin, carboplatin can also be used. So, however, small cell lung cancer commonly has a recurrence in the central nervous system. So, prophylactic cranial radiation is usually considered after complete response. So that means you give etoposide cisplatin, then after that, when the complete response is achieved to prevent recurrence, that is when we are going to consider prophylactic cranial radiation. So still, for extensive disease, we normally use etoposide cisplatin, but concurrent radiotherapy is not readily used. So the chemo regimen can actually, even alone by itself, can achieve complete remission. Riha, yes, please.
Sorry, sir. Sorry, it was by
Yes.
mistake.
Oh, it was by mistake, huh?
Yeah, sorry.
Okay, no problem. Then extensive disease, we normally give only the chemotherapy. Once we achieve complete remission, that is when we are going to initiate what? That is when we are going to initiate prophylactic cranial radiation. So after the primary treatment, there is a possibility the disease can recur when during the follow-up period. So treatment will depend on the type of recurrence, like what we have seen in ovarian cancer. So if the time of recurrence is actually less than 6 months, we can say like the patient is already resistant for that primary treatment regimen. So we have to use second line therapy, usually CAV. Topotecan alone or CAV can be considered cyclophosphamide, doxorubicin, and vincristine. But if the recurrence is actually above 6 months, that means the tumor is sensitive for the primary treatment regimen. We can actually repeat the same initial regimen. So this is how we're managing recurrence cases. So in summary, when a patient is actually having small cell lung cancer, when there is a limited disease, you give chemoradiation, cisplatin, etoposide, then radiotherapy. Then when the complete remission is achieved, that is when you are going to consider prophylactic cranial radiation. For extensive disease, we give chemotherapy alone, etoposide plus cisplatin. Then when the complete remission achieved, that is when you are going to consider prophylactic cranial radiation. So this one is a complete summary of what I said. So limited disease, mostly for cycles of etoposide, cisplatin or etoposide carboplatin plus concurrent radiation is usually given when the complete remission achieved. That is when you are going to give what? A prophylactic cranial irradiation. For extensive disease, we normally give toposide cisplatin for 2-6 cycle or toposide carboplatin for cycle. Then when the complete remission achieved, there is a prophylactic cranial radiation we are going to give. Then after that, for relapse or progression of the disease, if less than 6 months, we normally give. If greater than, we repeat the original regimen. So this is actually a brief summary how we manage small cell lung cancer, even in the context of our setting. Then, when you look at the chemo regimen, remember etoposide cisplatin, the toposide dose is usually 100 milligram per meter square IV, day 1 to day 3, plus cisplatin 100 milligram per meter square IV, day 2. Then you repeat every 28 days. If the regimen is carboplatin, still the etoposide dose is the same. Carboplatin AUCO 5 to 6, 5 to 6 can be considered on day 1. Then the etoposide will be given for 3 days, and we repeat every 21 days. By the way, the frequency of dosing or the cycle of chemotherapy started from day 1. So by the way, when you are counting when we are going to administer, we have to look at the day 1 of etoposide, not day 3 of etoposide. So we count from day 1 of the chemo administration when we are counting the cycle. Okay, so this one is, I think, simple and straightforward. So you can actually even study further when you need. Then, when you look at the non-small cell lung cancer, is usually the first step in the treatment involves confirmation of the clinical stage and determination of resectability of the tumor. By the way, in non-small cell lung cancer, surgery is really the front line in the management. So specifically in localized disease, when you do even surgery alone, it can actually even effectively treat or cure the disease. So stage 1, 1B, or 2A, surgery alone can be can be curative, but after surgery, in case if the surgical margin is positive, that is when you are going to consider radiotherapy and resection can be recommended. Like we're going to resect again or we radiate the area depending on the preference of the patient and the status of the patient. However, in majority of the case of locally advanced diseases, most of the time, adjuvant chemotherapy is usually recommended. What is very common in our setting is carboplatin paclitaxel regimen is the most common adjuvant chemotherapy in locally advanced stage of the disease. But mostly in stage 1, surgical resection can be alone, then you monitor. If the margin is positive, that is when you are going to consider radiotherapy. Then there is a scenario whereby even a locally advanced disease, you can actually even consider neoadjuvant chemotherapy. So this is where when the tumor size is actually very big. Otherwise, in majority of the cases, most of the locally advanced disease, we normally give what? Adjuvant chemotherapy. Okay, but in most of neoadjuvant chemotherapy is not really very common unless the tumor size is very big, but in most of the cases, we can consider in stage 3 is most common in a patient with locally advanced tumor, stage 3. Okay, fine. But there is a scenario whereby in case if the patient is locally advanced stage, but you are not able to resect the disease, the like resectability of the tumor is not possible. Normally we give active platinum containing regimen and radiotherapy can be considered even in this disease. So the surgeon, that is why cancer treatment is a multidisciplinary team. Specifically with solid malignancies, there is a role of surgeon and there is a role of like radiologist and there is a lot of even the medical oncology. So they normally agreed what treatment option we are going to decide for that specific patient is based on his or her condition. But in advanced stages of the disease, most of the time, chemotherapy is usually the front line because in advanced stage, the goals of treatment is usually what? The goals of treatment is like improve overall survival. Yeah, that is the primary goal. So according to the current guidelines, platinum-based regimens are usually produce the highest overall response and survival rates. So because of that, in advanced stage of the disease, mostly we are going to use what? We are going to use platinum-based analogs. By the way, they normally did like a study about the platinum-based doublets. Cisplatin with gemcitabine, carboplatin, cisplatin, paclitaxel, then docetaxel with cisplatin. Then finally, they find out is less life-threatening toxicity and treatment-related disease associated with paclitaxel and carboplatin. That is why currently this regimen is the treatment of choice. So according to those comparative studies, like this regimen is more effective and less life-threatening and reduce side effects. Okay, now how do we treat recurrence disease? So recurrence disease will be depending on the recurrence. If the recurrence is localized, surgery option can be assessed. If the recurrence is normally localized, maybe you consider surgery. But if the patient performance scale is acceptable, but then when you say the higher the performance scale means like the patient is actually having some limitation in mobility, like the patient is severely sick. So second line chemotherapies can be used as a single agent. Chemotherapy can also be considered. Then when there is a recurrence in poorly performance status like 3 to 4, usually no treatment with chemotherapy, so instead supportive care can be considered. Remember, performance status is really very key when you are initiating chemotherapy. So in summary, how do we treat non-small cell lung cancer? If the disease is stage 1 or 2, mostly you do surgery, but majority of the cases for stage 1 disease, surgery alone is curative. But stage 2, you do surgery, then after that you consider adjuvant chemotherapy. Then stage 3A, maybe you consider neoadjuvant chemotherapy or surgery or adjuvant chemotherapy. So depending, like if they do neoadjuvant chemotherapy, then they do surgery. After that, they consider adjuvant chemotherapy. So there is like for stage 3, mostly like the neoadjuvant options are not really, there is a lot of controversies. What is very common, even in stage locally advanced disease, is usually adjuvant chemotherapy use is usually very, very common. But if the degree of the disease is stage 3B, you give chemotherapy plus or minus radiotherapy can be considered. But in advanced stage of the disease like metastasis, chemotherapy and targeted therapies are usually the preferred treatment option for lung cancer management. So can you see even the difference between the two? When you see small cell lung cancer, cisplatin etoposide is a front line in the management, and even the role of surgery is actually very minimal, and even radiotherapy is only considered in limited stage of the disease. However, in extensive disease, we normally give a prophylaxis. So that is why the platinum-based analogs are usually the front line in the management of small cell lung cancer. So as I mentioned before, this regimen is usually very common: cisplatin, paclitaxel, carboplatin, paclitaxel. So remember, when a patient is taking a drug, paclitaxel with other combination, paclitaxel should be given first. Yeah, that infusion should be given first so that to reduce risk of side effects. Okay, paclitaxel mostly 135 milligram per meter square IV day 1, and cisplatin 75 milligram on day 2. Then you repeat every 21 days. Then carboplatin dose, remember, is based on Calvert formula. So AUC of 6 and paclitaxel 20-25 milligram per meter square. So those are the approved protocol. But the other regimen can also be used. Even the monoclonal antibodies, bevacizumab, can also be considered in the treatment protocol. Okay, by the this is all what I have in management of lung cancer. This is all about how we manage if we do have a patient with lung cancer. Any trial? By the way, we are almost 45, but I have seen it's a maximum of 4 students are actively participating. Myra, what is lymphoma based on your understanding?
I think it's the cancer which affects the lymph nodes.
Yes, it is a cancer which is actually affecting the lymph nodes. Yes, but by then there is also another. Don't confuse lymphomas with leukemias. There are actually some leukemias which is originated from the bone marrow, but this one, lymphomas, is actually a cancer which is mainly affecting the peripheral lymph nodes, not in the bone marrow. But those lymphomas can actually even invade in the bone marrow and causes bone marrow suppression. Good observation. Is there anyone who came across a patient with having lymphomas? Anyone? No. Okay, good. So there are different areas of lymph nodes, mainly in the neck, armpit, and inguinal regions. Sometimes even the mediastinal area of the lung. So those are actually even in the abdominal areas. They are lymph nodes. So you will see sometimes a mass in the abdomen, but we don't know what it is. But what is very common is mostly this swelling of lymph nodes in the armpit, swelling of lymph nodes in the inguinal region, and even swelling of lymph nodes in these areas around the neck regions are very common. So if you encounter a patient which is actually like a palpable type of a mass in the lung, and in these areas, it is good to undergo further screening for the presence of lymphomas. By the way, most of the clinical presentation of lymphomas are similar to Mycobacterium tuberculosis infection. If you remember TB causes normally lymphadenopathy, TB causes night sweat, TB causes weight loss, TB causes normally fever. So all those features are actually also clinical presentation for lymphoma patients. So that is why most of the general physicians, they usually confuse whether this patient is really having TB or lymphoma. They initially suspect lymphoma, TB. Then when they do a test for TB, the patient was negative. So this mass can really be a lymphoma. So most of the cases we'll get in our setting, they do have this kind of history. Initially, they do a TB test, but then later on, when they're actually doing further investigation, they normally diagnosed with lymphomas. So what is the objectives of this session? So at the end of this session, we are expected to differentiate between Hodgkin's and non-Hodgkin's lymphoma. So HL means Hodgkin's lymphoma, NHL means non-Hodgkin's lymphoma. So those are the most common type of lymphomas. There are actually different subtypes, but most of the cases, they normally put the diagnosis Hodgkin's lymphomas or non-Hodgkin's lymphoma. Then staging of criteria, identify the classic signs and symptoms, and outline the treatment modalities for early and advanced stages, and outline the general treatment approaches for follicular, indolent, and diffuse aggressive type of non-Hodgkin's lymphoma. There are some which are very aggressive and which requires immediate attention. So when you say lymphomas, they are hematological cancers that consist of cluster of diseases of the lymphoid tissues. So it starts in the white blood cells called lymphocyte, and the primary malignant cells for the lymphomas are lymphocyte of the B cell, T cell, and natural killer cell origin. But this one is actually very rare. So most of the cases of lymphomas, they are originated either from the B cell or from the T cell, but most of them they are originated from the B cell. Okay. Okay, then they are actually predominant in the lymph node areas. Then these lymphomas, they can actually infiltrate to other tissues, including the bone marrow. If they involve the bone marrow, they can actually cause bone marrow suppression. They can actually involve the CNS and causes CNS lymphomas. They can affect even the GIT and liver and even medicinal areas, skin and spleen. So depending on the organ involvement, there is a possibility the patient will have different clinical features. Then classification of lymphomas are generally into two, either Hodgkin's or non-Hodgkin's lymphomas. By the way, the best distinguished marker from the biopsy of the lesion is there is red Steinberg cells, as you can see from the diagram. So these red Steinberg cells are usually typical of Hodgkin's lymphoma. So if a patient is positive for red Steinberg cell for microscopy of the biopsy, so this is the patient is actually having Hodgkin's lymphoma. Okay, so this is the major factor how we differentiate between Hodgkin's and non-Hodgkin's lymphoma. Otherwise, in terms of clinical features, it is very hard to differentiate between the two. So this one is the most common test, but I will tell you later the other tests to differentiate between the two. So first, let's see about Hodgkin's lymphoma. So Hodgkin's lymphoma can occur at any age, but it is very common in the early adulthood, in the age of 20s, or in the late adulthood after the age of 5. So it has bimodal distribution. So it is very common in male than in female, but no one knows why it is very common in male than female. And it accounts 30% of all lymphomas. By the way, 30% of all lymphomas are Hodgkin lymphoma. So the 70%, the remaining 70% are usually accounted for non-Hodgkin's lymphoma. So epidemiologically, non-Hodgkin's lymphomas are the most common type of lymphomas. So that means they are actually non-Hodgkin's because they don't have red Steinberg cells when you do microscopic examination of the the cancer cells. Then there is a classification of Hodgkin's lymphoma. There is classic and nodular lymphocyte predominant. What I'm advising you, don't bother about most of the time, even most of the oncologists, they don't really put the type of classification, they just put either classic or nodular lymphocyte predominant lymphoma. So this classic type of lymphomas are usually the most common type of non-Hodgkin's lymphoma. So when you look at even the pathology report, most of the time they put classic Hodgkin's lymphoma. So even within their classic or non-nodular lymphocyte predominant, the treatment modalities are still the same. I think that is why they are not this much bothered about the types of the classifications of Hodgkin's lymphoma. So anyway, those are the two general classification, and classic is the most common one. Then what causes malignancy of the lymphocyte? So far, the precise cause is not known, but there are some epidemiological studies that showed a link between Epstein-Barr virus infection and Hodgkin's lymphoma, and even HIV infection and Hodgkin's lymphoma. So they are saying viral infections are usually correlated with Hodgkin's lymphoma, but the exact cause is not really known so far. Then there's also some epidemiological studies, but I'm not able to explain is the risk is actually very high in high socioeconomic ground population. I don't know why this viral infection is very high in socioeconomic status, highly socioeconomic status families. But anyways, this one you can consider it. But what is very key to note in terms of risk factor is the family history, the possibility of HIV infection, and the possibility of EBV virus infection. Those are like well-known risk factor that can increase the risk of having Hodgkin's lymphoma. Then, what causes Hodgkin's lymphoma is mostly the EBV virus, because this virus can cause DNA damage in B lymphocytes, leads to the development of these cancer cells, then which is the cancer cell in Hodgkin's lymphoma. So remember, these red Sternberg cells also make substances, we call them cytokines, which attracts many other cells, some substances in the lymph nodes, and ultimately causes enlarging of the lymph nodes. So there is a red Sternberg cells that can be overexpressed in Hodgkin's lymphoma patient, then these red Sternberg cells attract many more cytokines and ultimately causes enlargement of the lymph nodes. In such a way, they can actually cause lymphadenopathy. Then apart from that, there is another immunohistochemistry test, which we call it immunohistochemistry test, can be done by some facility. There is a possibility to identify some CD marker. So if a patient is actually, from the biopsy of the sample result, if there is a CD15 and CD30 expression, that is most likely the patient is having Hodgkin's lymphoma. By the way, most of those CD markers are usually to differentiate between Hodgkin's and non-Hodgkin's lymphomas, but the pathology result even will tell us whether it is Hodgkin's or non-Hodgkin's lymphoma. However, in non-Hodgkin's lymphoma, the CD20 receptor overexpression is usually very common. It is very, very common. But in this case, they're actually, these surface markers are usually not common in Hodgkin's lymphoma. So this is another mechanism to differentiate between Hodgkin's and non-Hodgkin's lymphoma. Then what will happen, by the way, when there is overexpression of proliferative and anti-apoptotic transcription factor, nuclear factor kappa B, this one is responsible for expansion and survival of red Sternberg cells. So remember, as a result of the red Sternberg cells There's also overexpression of nuclear factor kappa B, which is a transcription factor, proliferative, and also have anti-apoptotic transcription factor. So in such a way, they can promote the survival of their own cell. Okay, then when you come to the staging, stage 1, as you can see, is localized disease is involving a single lymph nodes or single organ. When you say stage 2, 2 or more lymph nodes are involved, but on the same side of the diaphragm, as you can see. Then stage 3 is 2 or more lymph nodes, but on different sides, like above and below the diaphragm. That is when we say stage 3. Stage 4 is widespread, and there is involvement of other organs. Can you see even here, the lung is involved, and there is also even the bone marrow is actually involvement. So that is when we say the patient is having advanced stage of the disease. So having said this much, now let me take you through about the clinical presentation. So the clinical presentation, mostly, the reason I mentioned, because of attracting of many inflammatory mediators and cytokines, lymphadenopathy is very common, but mostly it is painless lymphadenopathy, and often in the neck region, where the lymph nodes are predominant. Then, if the spleen is involved, you are going to see the splenomegaly. But sometimes, if the mass is actually in the mediastinal region, now it can cause shortness of breath, dry cough, chest pressure can happen. Then, back chest pain and abdominal pain is very common in case if the pain if there is involvement of the abdominal areas. Then another thing to note, in 25% of lymphoma patients, itching at the site of a large lymph node is very common. Why? It is actually because of cytokines. So cytokines are the one that can actually increase risk of itching in lymphoma patients. So if a patient is actually complaining long-term itching, don't go actually even not only see the aspect of some skin infection or any other kind of skin problem, but it can be even a lymphoma. It can be even a lymphoma because of the large proportion of cytokines that can cause the skin itching. Then there is another thing we call it like B symptom in lymphoma patient. So like by the way, the word B is given, it is referring to the presence of B symptoms, just like a naming. Yeah, if they don't have, they put A. If they have B symptom, they put B. So anyways, B symptoms are the fever, night sweat, weight loss. Can you see even those things are more or less similar to TB infection? We call them, but not all patients normally present with B symptom. About 40% of the population will have B symptom. However, there is a possibility a patient can have lymphoma without having those B symptom, but it is good to check. Okay, then diagnostic modalities. How do we make up a diagnosis of lymphoma? Bone marrow biopsy is very, very important. Do you know some kind of leukemias, like acute lymphoblastic leukemias, can cause even lymphadenopathy? So unless you do bone marrow biopsy and confirm, the problem is actually from the bone marrow or not. It is very hard to rule out whether the patient is having acute lymphoblastic leukemia or not. So you have to check. But most importantly, biopsy of the suspected lymph nodes are usually the gold standard. Then apart from that, immunohistochemistry is also very important so that you can differentiate between whether the patient is having Hodgkin's or non-Hodgkin's lymphoma. Remember, those CD markers are usually overexpressed when a patient is having Hodgkin's lymphoma. Then chest X-ray to see whether there is enlargement of lymph node in the chest. CT scan can also be considered. Bone scan, if you are expecting bone involvement. Then CBC is also very important. So why CBC? Because if there is like this cancer originates in the peripheral tissues, but they can actually invade the bone marrow and cause abnormal blood cell count and even causes anemia. So you'll see a lymphoma patient can be anemic because of when there is a bone marrow involvement. Then the ESR, erythrocyte segmentation rate, is actually a marker of inflammation. So it can be elevated in some Hodgkin's lymphoma patient. But this one will tell us a lot of information. It can be an inflammation, it can be an infection, but we don't know because it is not a specific tumor marker. Then sometimes even the lactate dehydrogenase enzyme can be elevated in lymphoma patient, but still it is not specific marker because LDH can also be even elevated in breast cancer patients. So because of that, it might not really very accurate in the diagnosis. So those are the key diagnostic tests we are going to do, but mostly biopsy of the suspected lymph nodes and immunohistochemistry tests are usually done to even put classification of the type of lymphomas. Okay, then any questions so far? Maybe before we start the management, any question? Questions so far? So are we together?
Yes.
Yes.
So I'm hoping you're actually actively listening because those are the kind of cases you will get it if you are working in the oncology area. So I'm encouraging all of you to attend as much as you can, despite the session is very long. So now we know what is Hodgkin's lymphoma, yes? And we know how does a lymphoma patient present with, and we know how we are going to come up a diagnosis of lymphoma. And now, how do we manage Hodgkin's lymphoma? So by the way, regardless of the stage of the disease, Hodgkin's lymphomas are very sensitive and it is one type of curable type of hematological malignancies, either chemotherapy or radiotherapy, but mostly in localized disease, we normally give combination therapy. So our goal is, regardless of metastasis, our goal is normally to cure. The goal is just curative intent. Then treatment-wise, there are two strategies. Early stages, we call them stage 1, 2. Then advanced stages, we call them stage 2 and 4. So the treatment strategy for early stages 1 and 2 is the same, and the treatment strategy for stage 3 and 4 is the same. So how do we manage early stage? Combination treatment modality is usually the front line. So you give them 2 to 4 cycles of ABVD. By the way, now listen carefully. If you see a patient with Hodgkin's lymphoma, the primary treatment is usually ABVD. Chemotherapy is the front line in the management. So maybe next time when you go there, make sure when they are actually talking about ABVD, when they encounter a lymphoma patient, Hodgkin's lymphoma. So what does A stands for? A is for adriamycin, which is the same as doxorubicin. B is for bleomycin. V is vinblastine. Don't confuse by the vinblastine with vincristine. What we are using for ABV, what we are using for Hodgkin's lymphoma is vinblastine, not vincristine, because they are actually in the same class. Then the other one is dacarbazine. So you give them 2 to 4 cycles, followed by radiotherapy for minimum of 4 weeks. That is the primary treatment. And then after that, after you do primary treatment, the next treatment approach is you monitor the patient. If there is a relapse, there is a protocol how we are managing relapse cases after primary treatment. Okay, if the patient is having advanced stage of the disease, we have to give what? 6 to 8 cycles of ABVD regimen. So ABVD is the most common and the most effective regimen in lymphoma patients. So now, what are the dosing schedules of ABVD? By the way, doxorubicin is usually given 25 milligram per meter square, and you give them IV day 1 and day 15. Bleomycin is in terms of international unit. By the way, this is almost, yes, this is 1 international unit, sorry, 1,000 international unit is equivalent to 1 unit. So like this one, the patient is actually taking 10 unit, 10 unit of bleomycin per meter square. Okay, then day 1, day 5, vinblastine 6 milligram, dacarbazine 375. Then you repeat every 28 days. Now, please note that there is a need to calculate the cumulative dose of bleomycin after 6 cycles. So what is the reason to calculate the cumulative lifetime dose of bleomycin after 6 cycles? What is the reason? What is the reason? I think I mentioned when we are discussing about the introductory sessions of chemotherapy, I mentioned about some toxicity, specific toxicities for bleomycin, specific toxicity for doxorubicin. So what is the reason?
Is it because of hypertension and impaired wound healing?
No, that one is bevacizumab, not bleomycin.
Pulmonary toxicity.
It is just because of pulmonary toxicity. By the way, the maximum dose you can give for bleomycin is for 100 unit. That is equivalent to 400,000 international unit. If you give them beyond that, the possibility of pulmonary fibrosis is actually very high. That is why, you know, some people, they do have actually larger body surface area. Because of that reason, you normally check the cumulative life dose. If that is achieved, there is a possibility. So this might not be a drug of choice, and you have to even consider to change the regimen. Then even for doxorubicin, by the way, with this dose, it is very unlikely to achieve the maximum cumulative dose. But when you give in the AC regimen, because in that AC regimen, it is 60 milligram per meter square, so there is a possibility for, so the cumulative toxicity is 450 to 550 milligram per meter square. Even for doxorubicin, you have to calculate the cumulative lifetime exposure. If the total is actually below above this point, now there is a possibility of what? Cardiotoxicity. Because cardiotoxicity of doxorubicin is mostly by generating free radicals. Those free radicals are actually cardiotoxic in nature. You know, by the way, we do have a drug that can actually counteract the toxicity of doxorubicin. They can actually even chelate, but I'm not very sure about how available that antidote is. We shall see later at the end of this PHM 5487 unit. So anyways, those are the kind of things you are going to look at it. Otherwise, ABVD is the front line in the management of what? Hodgkin's lymphoma. Okay, good. Now, if you do have a relapse case, you have given normally, the patient achieved complete remission, but after some point, there is actually what? Relapse. Then, so depending on the previous treatment, the salvage therapy includes, you can consider radiotherapy, chemotherapy, even high dose chemotherapy with autologous stem cell transplantation. By the way, this one is not possible in our setting. But this one is just one of the salvage therapy that can be considered. What they usually do is they take stem cell when the patient is actually under complete remission. They take and reserve the stem cell. Then after that, what they normally do is they give high dose chemotherapy when they are doing stem cell transplantation. So that is, we call them high dose chemotherapy with autologous stem cell transplantation. But in our setting, those are the strategies. Strategy 1, 2, 3, salvage radiotherapy, chemotherapy, and high dose chemotherapy. Those are the strategies that can be used for relapse cases. Okay, now, if the duration of remission was above 12 months, that is like late relapse, then we can treat the initial regimen. The initial regimen can be, because like here, the relapse time is actually longer. So in that condition, we can consider to do this. Initial chemotherapy can be considered or repeated, or salvage regimen can be used, or high dose of chemotherapy if it's available with a stem cell transplantation. So the autologous stands for like the stem cell was extracted from the same person. That is why it is auto means self. I think you know these Latin words. Then if the relapse occurs less than a year after treatment, that is early relapse, so high dose chemotherapy can be considered. Then in case if the patient never achieved complete remission, that is primary refractory disease, they usually give high dose chemotherapy. So those are the salvage regimen that can be considered even in our setting. I think in our setting, the ICE and IVA regimens are the one which is commonly given. I'm not very sure about the DHAP and ISHAP regimen, whether how frequent, but remember, as I said, depending on the oncologist, you can actually even use a different protocol. So the IS and IVA regimen are actually the most commonly used regimen for salvage treatment. So in case of relapse, then you monitor the patient. Okay, now this one is normally this one is already, I've already said, the treatment protocol of Hodgkin's lymphoma. So in summary, you give in the early stages 2 to 4 cycles of ABVD, then you radiate for 4 weeks. Then if it is advanced stage of the disease, you give them only chemotherapy, but then you assess the possibility of relapse. Okay, fine. Now, the next step we are going to see is prognostic factors for Hodgkin's lymphoma. Those are the prognostic markers or poor prognostic markers. If the patient's hemoglobin level is actually very low, older age, advanced disease, high WBC count, low lymphocyte count, those are the poor prognostic markers of lymphoma. Okay, so those are some information you are going to look at it when you get time. But now, let me take you through about non-Hodgkin's lymphoma. So do you have any questions so far about Hodgkin's lymphoma? Okay, fine. If so, now we can see non-Hodgkin's lymphoma. So this one is a heterogeneous group of lymphoid malignancies that can range indolent, which is slow growing, or very aggressive type, which is very fatal disease. So the more aggressive ones are more susceptible to anti-cancer therapy. They are very aggressive and they are actually very susceptible for treatment. Okay, then, do you remember what I said in the epidemiology? Non-Hodgkin lymphoma accounts 70% of the cases. Hodgkin's lymphoma accounts 30% of the cases. So we do have B cell and T cell, but most of them are actually originated from the B cell. Then non-Hodgkin's lymphoma may be indolent, slow growing, or aggressive or fast growing, as I said before. Then the most common type of non-Hodgkin's lymphoma in adults are the diffuse large B-cell lymphoma, and follicular lymphomas are usually very common, even in the clinical setting. So some oncologists, they put non-Hodgkin's lymphoma, but some, they put the type of non-Hodgkin's lymphoma, like diffuse large B-cell lymphoma, follicular lymphoma, mantle cell lymphoma, and etc. But follicular ones are usually indolent and slow growing. And now we have seen when we are discussing about non-Hodgkin's lymphoma, Hodgkin's lymphoma is bimodal in the early 20s or in the late 50s. But this one is usually very common in older population. So it is very likely to see this condition under the age of 30. And the incidence increases as we age. And you can actually even see the mean age of diagnosis is very in the late 60s. So it's very common in men than men. Like this is 1.5 to 1. That is the ratio of the incidence. So the risk is higher in men, but nobody knows why it is common in men. So what are the possible risk factors? But they still like that of Hodgkin's lymphoma, the exact etiology is not really known. That human herpes virus 8, hepatitis C infection, HPV, malaria infection, and human cell leukemia virus 1, those are the most common etiologies, apart from the environmental factors, some chemical exposure. So, by the way, especially in malaria endemic areas, in the East African setting, it is very like the Burkitt's lymphoma is very common. I will show you at the end. Yeah, I hope we'll finish this one for today. So, malaria, chronic malaria infection can cause some malignant transformation in the lymphocyte. That is why in malaria endemic areas, usually that condition is usually very high anyways. Okay, then I've said the classification, the BCL 85%, the TCL account is 15%. So the BCL type can be low grade, can be aggressive, can be even high grade, very fatal. And they can actually even behave like acute leukemias, usually the Burkitt's lymphoma. So those are the types of the B-cell type of non-Hodgkin's lymphomas. By the way, do you know how they differentiate between whether it is originated from the B-cell or T-cell? They are actually having the CD marker. By the CD marker 5, 9, 7, 10 usually indicators if there is overexpression of the low CD4 count, CD4 marker, smaller number, they are most likely what? They are most likely non-Hodgkin's lymphoma. But this one is usually they overexpress CD20, some of them CD19, sometimes even CD38. So those are the markers of B-cell lymphomas. But most of the time, even the histology result will show you whether it is originated from the B-cell or from the T-cell. But most of in our setting, we'll get a B-cell lymphoma. Maybe, can you see about, you can actually even see the types of non-Hodgkin's lymphoma. Indolent, we do have many, but this one is very common from slow growing. From aggressive, one, diffuse large B-cell lymphoma is very common, but very aggressive one, Burkitt's lymphomas are the one which is very common. But anyways, all those are the type of non-Hodgkin's lymphomas. So most likely, by the way, those are the three things you are going to get in our setting. Yes, follicular, diffuse large B-cell lymphomas, then T-cell lymphoma you can still get, and Burkitt's lymphoma. This one is very aggressive and it requires even immediate treatment. Okay, fine. Now staging is the same. Staging is normally the same like that of Hodgkin's lymphoma. Maybe is there anyone who is willing to give us how do we stage? What does stage 1 means in the context of non-Hodgkin's lymphoma? Anyone? Any trail, please. Huh?
Sir, can we say it is localized at the stage of the first stage of of infection or
So stage 1 means it is involvement of single lymph node. Yes. Stage 2 is 2 or more lymph nodes, but in the same region. As you can see, it is above the diaphragm, both of them. Stage 3, involvement of lymph nodes on both sides of the diaphragm. Yes. Can you see even here and here? Then stage 4 is normally there is diffuse extra lymphatic disease. Can you see even the liver, the bone, marrow, and the lung is involved? You know, by the non-Hodgkin's lymphoma, there's also a lymphoma in the skin. I don't know, maybe you will see if the lymphoma is involving the skin, you'll see some kind of dot markers on the skin or some kind of swelling on different parts of the skin. Cutaneous lymphoma is also I have seen. So like you will get like different types of anyways and Hodgkin's lymphoma, but what I said is the one which is actually very common. Then in terms of clinical presentation, by the way, it's very hard to differentiate between the two. The painless lymphadenopathy is still common for both. If there is involvement of the bone marrow, you are going to see bone marrow suppression, so sign of infection, anemia, and thrombocytopenia can happen. If there is involvement of the liver, you'll see the enlargement in the liver and the spleen, also derangement in the liver enzyme. Yes, sir. Then the B symptom can be present, like night sweat, fever, and weight loss. Don't forget this one. They're actually more commonly seen in advanced or aggressive types of lymphomas in majority of the cases. So lab findings, anemia can happen, ESR can be elevated, and LDH can be elevated, as I said before. Then diagnostic test, history, physical examination, lymph node investigation, but definitive diagnosis only can be done by biopsy of the pathologic lymph nodes. Yes. So CT scan of the other organ to see the extent of the tumor. Lumbar puncture can be, by like the possibility of CNS involvement is very high, specifically with the Burkitt's lymphoma. If there is CNS involvement, it can actually even causes a very fatal consequence. So lumbar puncture can be considered because the aggressive type of non-Hodgkin's lymphoma, such as Burkitt's lymphoma, they can invade the CNS easily. So otherwise, there is no much difference in between the two. So now, let me take you through about how do we manage this condition. Okay, how do you manage this condition? So the management will be depending on the age, the extent of the stage of the lymphoma, and the histological type of the disease. So remember, if the lymphoma is low grade, and most of the time, it normally run a slow course and there is no possibility of cure. So patients survive for a prolonged period with minimal symptom. So there is no cure for non-Hodgkin's lymphoma of low grade. So, but the period is actually very slow growing. Aggressive high grade like Burkitt's lymphoma can die within weeks or months if not treated, but they are very responsive to treatment. And up to 50 to 60% can be cured with combination chemotherapy. Then, if so, how do we treat follicular low-grade non-Hodgkin's lymphoma? Okay, in case the patient is asymptomatic, watch and wait policy can work, but mostly in the early stage of the disease, radiotherapy is usually the front line in the management. Because here, the goal is not to cure. The goal is actually to improve quality of life of the disease. So radiotherapy of the involved field is usually recommended. However, for stage 2 and 4 diseases, chemotherapy, now here we are going to use R-CHOP regimen. So remember, for ABVD for Hodgkin's lymphoma and R-CHOP for non-Hodgkin's lymphomas are the front line in the management of this condition. Okay, so as I said before, combined treatment modalities are usually recommended for aggressive type. If it is aggressive type, you better use combined modality in the early stage, CHOP followed by radiation. But if it is low grade with early stage, you better do radiation therapy alone. But still, the chemo regimens are the same. I don't know whether you know the difference between the management between diffuse and diffuse aggressive lymphomas and follicular lymphomas. Yes, so this one we normally use combined treatment modalities, CHOP followed by addition therapy, but in advanced stages, that is 3 and 4, we are going to give what? 6 to 8 cycles of R-CHOP chemotherapy. Then now, what is R-CHOP regimen? So R is for rituximab, C is for cyclophosphamide, H is doxorubicin, O is oncovin, vincristine, P is prednisolone. You can see the doses: 375, doxorubicin 50, vincristine. But the maximum dose for vincristine is actually 2 milligrams. Despite whatever the body surface area of the patient, if it is go beyond 2, we normally give only 2 because of neurotoxicity issues. Cyclophosphamide, 750 milligram, prednisolone 100 milligram daily for day 1 to day 5, then you repeat every 21 days. So this one is normally given if a patient is having CD420 positive B-cell lymphoma. So remember, rituximab is a monoclonal antibodies that are specifically targeting the CD20 overexpression in majority of lymphoma patients. So if the patient is actually do not overexpress CD20, we don't give rituximab, it will be CHOP. But more than 80% of our patients, they are positive for CD20 when they are having non-Hodgkin's lymphoma. So now, don't forget about the pre-medication with acetaminophen for fever and diphenhydramine normally to prevent infusion-related reaction due to rituximab before chemotherapy. Those are the pre-medication. I think that is all how we are managing. That is the whole aspects of R-CHOP regimen. And I said this one is actually very common in non-Hodgkin's lymphoma. Then this is normally the treatment algorithm. So like for low grade, radiotherapy is usually considered, but low grade stage 4, 3, that is when we are going to consider R-CHOP regimen. Then for intermediate and high grade, like this one, chemotherapy with radiotherapy can be considered, but in advanced stage, we're going to give 6 to 8 cycles of chemotherapy. So I think that is all. That is all about management of Hodgkin's lymphoma, non-Hodgkin's lymphoma. Okay, towards the end, there is Burkitt's lymphoma. This one is very aggressive type of non-Hodgkin's lymphoma. I don't know whether you came across a tumor like this, which is actually involving the jaws. Is there anyone who came across this type of tumor? It is very common by the in the East African setting. Anyone who came across this kind of tumor? You have never seen before, or you are not even there?
We've never seen.
Not
Okay,
seen.
you have seen. Where?
And maybe you see, then you think it's not cancer, maybe it's just like how a child is born.
It's usually the East African type of Burkitt's lymphoma is usually involving like the bow, the jaw of the bone of the jaws. So it's very common, by the way. Yes. So this one is a rare form of B-cell non-Hodgkin's lymphoma, but very aggressive, very common in children and young adults. So the median age of diagnosis is 30 years. So if not treated, it can kill. So combination therapy is usually urgently common. That is why this one is treated as like an acute leukemia, and there's a need of intensive chemotherapy, including even CNS prophylaxis. So the cure rate is very high. You can actually cure this one. Then multi-agent regimens are usually given. Codox M and IVAC regimen is actually the most frequent regimen in management of Burkitt's lymphoma. So cyclophosphamide, vincristine, doxorubicin, and high dose of methotrexate. So that is Codox M. Then IVAC is ifosfamide, etoposide, high dose of cytarabine. So those are the regimen that can be given, and usually cycle 1 and 3 involves Codox M, cycle 2 and 4 involves IVAC regimen. So usually 3 cycles of Codom X are usually enough for low-risk patients, but when the patient is high risk, a total of 4 total cycles are usually recommended. Yeah, that means 2 cycles of Codom X alternating with 2 cycles of IVAC. So in fact, that is the most one. Like odd and even cycle. By the way, when we're discussing about leukemias, we shall see. Like cycle 1, you give them this one. Cycle 2, you give them IVAC. So then cycle 3, you give them this Codom X. Cycle 4, you give them IVAC. That is why alternating Codom X and IVAC is the most common treatment modalities for what? For Burkitt's lymphoma. So by the way, you are not supposed to cram, especially with cancer protocol. Is actually very notorious and very hard even to cram. So this is how the Codo XM protocol look like. So don't forget why methotrexate leucovorin is added. It's just to counteract the anemia or the bone marrow suppression due to methotrexate, and also even there's a support of filgrastim, which is Nepogene, that can be given subcutaneously, because this one is really high or dose intense chemotherapy regimen. So the risk of febrile neutropenia is usually very, very high. Then this is IVAC regimen. Can you see even why MISNA is added here? Why MISNA is added? By the way, cytarabine, the other name is cytosine arabinoside, is cytarabine. It's also very common treatment modalities, but we shall see it when we are discussing about leukemias. So why MISNA is added here?
For ifosfamide.
Yeah, because of ifosfamide, they usually give it in the form of infusion, so to prevent the possibility of hemorrhagic cystitis. So those are the protocol that is mandatory to be included. Then another thing to note is when you treat high aggressive lymphomas, there is a possibility of tumor lysis syndrome. So tumor lysis syndrome is referring to a syndrome that is usually associated with treatment of cancer. So the moment you give them, the tumor undergo lysis, then when it undergo lysis, there is increased serum levels of electrolytes, mainly the uric acid level will be elevated, the potassium level will be very high, hyperkalemia, then the calcium level will be very low, and the phosphate level will be very high. Then as a result of even hyperuricemia, it can actually even causes acute kidney injury. But then that is why precaution should be done when you give high risk or high grade lymphomas because of tumor lysis syndrome, so that allopurinol is usually given as a prophylaxis to prevent tumor lysis syndrome, so that it inhibits the uric acid production. Then, yes, sir. So, sir, but we shall see it in detail. What is tumor lysis syndrome when we are discussing about oncologic emergencies, the last topic of PHM 5487. Okay, those are the negative prognostic markers. The older the patient, the poorer the prognosis. The advanced the disease is, the extranodal disease greater than one side, performance scale status 2 or greater. Yes, remember when the higher the number of the performance of status, the patient cannot tolerate even the treatment or the higher the disease, and high LDH level, that is poor prognostic markers of non-Hodgkin lymphoma. So this is all what I have about lymphomas. So now it is time to hear questions from you, whether you really learn something about lymphomas.